Managing cerebral edema, we also manage ventilation. On most of these patients are intubated. So an increase in CO2 often causes vasodilation, which can increase ICPs. So treatment is maintain adequate oxygenation, prevent hypercapnia, and for anybody that has a GCS less than 8, early intratracheal intubation. As trauma noted, that Megan did end up intubated when she came to the emergency room. Lots of other units might use hyperventilation to decrease CO2. That is never recommended in neuro patients. It actually can cause an increase in metabolites and lead to more secondary injuries. So we never do that in our units. Going hand in hand with ventilation is often sedation. Sedation lowers ICPs by decreasing metabolic demand and also facilitating mechanical ventilation. Neuro nurses love the drug propofol. Has neuroprotective effects. It's associated with ICP reduction, and trauma is usually very jealous of us with our propofol, I can say that. And it has an extremely short half-life, so we can shut the drug off, do a wonderful neuro exam, and then turn right back on, and that way we don't have to worry about ICPs, increasing heart rate, all that stuff we talked about with the storming. Rarely, sometimes we do use a barbiturate coma. This is usually used for when we want patients completely brain rested. There's less wake-ups involved with this, but there's not much clinical data to actually support this. In addition to ventilation and sedation, we also monitor temperatures. Fevers actually are pretty common in traumatic brain injuries due to the inflammation near the hypothalamus. It's part of the storming process. It actually increases ICPs and metabolic demand. Treatments often include Tylenol, which is antipyretic. We would never use aspirin or ibuprofen because that could increase their chance of bleeding again. Surface cooling blanket, and there's actually more research being done in intravascular temperature management where you cool the whole body. Glucose management, we also worry about glucose levels being too high or too low. This can actually increase acidosis and anaerobic metabolism, increase free radicals in the inflammation process, and increase the blood-brain barrier permeability. So our patients are always on blood glucose monitoring. Some are on a sliding scale, and if they need more tightly controlled, they actually end up on insulin drips with Q1-hour blood sugars. And finally, this is one of the things we manage actually probably the most prophylactically is seizure management and brain injuries. So an early post-traumatic seizure actually occurs less than 1 week of the head trauma. Usually does not represent epilepsy because it's a low likelihood of reoccurrence. It's about in 6 to 10% of the general TBI population. When it first presents in the unit, it's usually a tonic-clonic type if it's in the first 24 hours, and then it becomes more of a focal type. And treatment includes anti-epileptic drug therapy, including Dilantin and Keppra. Post-traumatic epilepsy actually occurs greater than 1 week after the initial head trauma. And I always have to read this because I'm really bad at this one. In the general population, it's about 2%, but as the traumatic brain injury severity increases, so does your likelihood for post-traumatic epilepsy. Unfortunately, Megan's had pretty severe brain injuries, we noted, with all her primary injuries, and she is currently suffering from post-traumatic epilepsy. Again, long-term treatment is anti-epileptic drug therapy. So now we're going to introduce Diane Cantella, and she's actually going to tell us about an up-and-coming research study with probably a pretty promising treatment. Yep, we're crossing our fingers.